مساء الخير على حضراتكم. طبعا أول حاجة حابة أشكر حضراتكم وأستاذتي الحبيبة قدوتنا أستاذة دكتورة شيرين عبد الغفار على النجاح الرائع للتجمع بتاعنا اللي بنستناه من السنة للسنة. حابة أقول لحضراتكم إن أنا التوك بتاعتي about the approach of virilized females. بس إحنا حابين نبتدي السين من ستيج بدري شوية. تخيلوا ان حضراتكم بتأتند a delivery room وبتreceive a newborn and you have the surprise of the genital examination and مش قادرين نحدد الطفل المولود ده is it a female or male. Let's start the questions اللي هتيجي في دماغنا during the assessment. Is it normal typical genitalia or abnormal genitalia? And the second question, is that a virilized female or under virilized male? And the third question is that time of presentation and diagnosis always at the newborn period or maybe later or earlier? And the last question, what is the stepwise approach of that diagnosis? For the first question, is it a normal typical genitalia or abnormal genitalia? The atypical genitalia, لما أنا مش قادرة أحدد the external genital examination أو appearance اللي أنا شايفاه قدامي could be assigned as male or a female with the term of ambiguity. طبعا حضراتكم كلكم عارفين the normal typical male with the normal single urethral meatus at the tip of the penis with the phallic size of 2.5 centimeter with the fused scrotal sac and scrotal roget and the normal female genitalia with the normal clitoris with clitoris length less than 0.8 centimeter, which is a very important information. And we have two openings, one urethral and one vaginal, totally separated labia. This is the normal shape for both male and external female genitalia. What about the other picture, as you see here? I think you cannot assign. It's a small phallus, a partially fused scrotal sac, under virilized but scrotalized. مش قادرين نحدد is it a labia or a scrotal sac. This is the picture of the surprise اللي احنا بنلاقيها في ال delivery room. طب what about the question, is that a virilized female or under virilized male? To solve that question في a lot of scores generated عشان نقدر identify which patient must be investigated. وده عشان نقدر نقلل طبعا investigations والexpenses اللي قدامنا. For that, external genital score, it's a neutral score as we say. قبل ما نقدر نحدد is it a female or a male child. The external genital score ده include كذا حاجة. The phallic length, the urethral meatus, and the labioscrotal fold, and the left gonad and the right gonad. This score must be less than 10 to be investigated, for the child to be investigated. After specifying is that the child is a female or male, we have a lot of scores like Quigley score for the under virilized male and the Prader and the external masculinization score, external masculinization score for the under virilized male and the Prader score for the virilized female. طيب, the third question, what is the time of the presentation and the diagnosis? It's usually at birth. لما بنلاقي السربرايز اللي احنا بنتكلم عليها. But less commonly during the pregnancy المother expect ده. لما بتبقى عاملة أي karyotyping وفي there is a discrepancy between the external genital appearance and the karyotyping اللي احنا لقيناه لما تبقى عاملاها for other reasons. And lastly ممكن يبقى delayed till the puberty لو البيشنت totally شكله male أو female وبدأ يبقى فيه other manifestation at the puberty. Let's start our algorithm. We have a neonate with a typical genitalia as we discussed before. We have to revise the prenatal history. During the pregnancy, is the mother is taking any medication? في أي signs of virilization ظهرت عليها؟ بعد كده لازم نعرف برضو the family history. في أي history of any similar condition in the family ولا لأ؟ في history of any neonatal deaths? Then we go to the clinical assessment for the hydration, the extent of masculinization, and the genital examination, which is the most important part. So we have to palpate for the presence of the gonad in the labial or the inguinal region, and we have two options. If we have no gonads palpated, mostly we have a virilized female, but not always. And if we have a gonad, mostly we have under-virilized male. Then we will go to the crucial step, the karyotyping. We have different options. We have a 46XX or 46XY or chromosomal sex disorder. Let's start our complicated algorithm for a newborn with atypical genitalia with 46XX karyotype. دي هتبقى suspected during the examination لو لقينا كذا حاجة according to the previous score. لو لقينا clitoromegaly more than 0.8 centimeter أو لقينا fusion of the labial folds أو لقينا less than 2 openings لقيناها. أول step بنعمل الkaryotyping بتاعنا. Then we have to confirm with FISH for SRY gene. It's the sex determining region on Y chromosome. We have two options. If it's negative for the SRY gene, we have to do the abdominal ultrasound to detect for the Mullerian structures, uterus, ovaries, tube. If yes, so we are suspecting the presence of congenital adrenal hyperplasia. Go for 17-hydroxyprogesterone. If it is elevated, we have to do the whole precursor sodium and potassium and glucose. We have different options for a female 46XX DSD with virilization secondary to congenital adrenal. We have the option of 21-hydroxylase or 11-hydroxylase or 3-beta-hydroxysteroid dehydrogenase. Let's go for the other limb of the SRY negative. If we don't have a Mullerian structures, we have 4 different differential diagnoses. Testicular disorder, testicular DSD, or ovotesticular DSD, or 46XX gonadal dysgenesis, and the less commonly the fetoplacental hyperandrogenism, secondary to aromatase deficiency or oxidoreductase, or a drug exposure during the pregnancy, or a virilizing tumor in the mother itself. Then go to the SRY positive 46XX DSD, and that is the surprise. We have a testicular determining region translocated to one of the X chromosome that promote for testicular development. We have to go further for another interventions like laparoscopy and biopsy, and we have two different differential diagnoses like testicular disorder or ovotesticular disorder, and it must be diagnosed by laparoscopy and biopsy. This is my algorithm, and thank you so much.